Welcome, everybody. So excited to have all of you today. One of the things we're gonna talk about a lot today. Sarah and I are doing this together, so you're gonna get a lot of information. I'd like to start out by first introducing myself. My name is Linda Lybert. I am the founder and executive director of HSI. I've been in the healthcare industry for over 25 years, and in particular, focused on surfaces, which we're going to talk about today. And Sarah, I'm going to turn it over to you to introduce yourself, please.
Hi, and welcome everyone. I'm Sarah Wilkerson. I am the Executive Director for Infection Prevention at Providence St. Joseph Health and an advisory council member for HSI. I've been a nurse for about 16 years, starting in the operating room and then moving into clinical education, where I ended up with infection prevention and have been in infection prevention for about the last 11 years. And really have enjoyed where that has led me. Thanks, Linda. Excited to be here today. Noticing I'll be keeping tabs on the chat and also our questions. So a couple of things right off the bat, we will be recording, as I think some of you had already asked. And please put any questions that you have in the Q&A box, and we will get to those as we can throughout. Thank you so much.
Good. So our learning objectives today is to understand infection prevention and begin, and the fact that it actually begins at design with the selection of surfaces. We're going to talk about the basics of microbiology. You're going to be empowered to evaluate surface materials and to evaluate instructions for use and care and maintenance documents. We're going to learn about the resources that are available to you, and then we're going to talk about how you can become actively involved with the Institute. So let's talk about the basics. There are 3 ways that microbes are transmitted: air, surfaces, and water. And what's really important is, of course, we can't see the microbial world as it exists. So a lot of assumptions are made just from visual inspection of surface materials and products. This is where the problem begins, because a lot of times we have surface materials that are in the healthcare setting that actually cannot be cleaned and disinfected. And what's happening is microbes will attach to these surfaces. They actually can move on surfaces, and they also develop biofilm, which we'll talk about a little more in detail in a few more slides. What is happening on surfaces is there's a lot of cross-contamination that takes place, not only via our hands, but also other surface materials that come in contact with those surfaces. And I often talk about the lab, when the lab tech comes into the patient room and they've got that little box with all the vials and they set it on an over bed table, which is one of the most contaminated areas in a healthcare facility. And so we want to make sure that that is something that is cleanable. The 2 pictures in the slide here, one is MRSA and the other one is rhinovirus. And it's interesting, the world, if you can see it through a microscope, you can actually see how many microbes truly exist. So research shows that even after effective and efficient cleaning and disinfection, microbes continue to live on surfaces. And I joke with my advisory board that, it's January because here comes the next flow of research that's letting us know that these pathogens continue to live. Part of the problem is that we are putting surfaces in our healthcare settings that cannot be effectively cleaned and disinfected. We can't clean them all the same. And so if we don't pay attention to this, what happens is damage occurs and tiny microbial reservoirs that become beautiful, safe harbor for these pathogens that are living on surfaces. There's a decades-old belief, clean and disinfect better. In fact, we have actually done a lot to try and improve the cleaning and disinfection process. We've changed guidelines, new protocols have been developed, better disinfectants. We've got UV disinfectants, we've got antimicrobial surfaces, yet the research continues to show an ongoing problem. And so we are here to tell you we need to address the very root causes, which is surfaces that are being used for products and in our environments, as well as getting a better understanding of the basics of microbes and what they're doing in our real world. So this is a photograph of E. coli. The little green rods are actually the bacteria, and it has attached to, which if you look in the background, you can kind of see a gray picture, which is the surface. And this is actually a rough surface, which the microbes find very pleasing for attaching to. Once it gets attached to the surface material, it begins to form this complex structure of microorganisms called biofilm. And that creates a protective coating around this grouping of microbes. It protects those microbes. So it's oftentimes very necessary that friction be included in the cleaning and disinfection in order to remove the biofilm. And biofilm is very difficult to remove. We once thought that biofilm formed only on wet surfaces, but now we understand from research that is ongoing that biofilm forms on perfectly dry surfaces as well. So we really need to understand this, and we really need to understand what surfaces are less likely for the microbes to attach to, and can we truly clean them? So this is one of my favorite photos. There are so many different types of surfaces and materials. If you stand in the doorway of a room within the healthcare setting, and really focus on the surfaces, not just on products, because in many products, there are multiple types of surface materials combined, but they can't all be cleaned and disinfected the same way. And there are more and more FDA recalls due to surface disinfection compatibility when we try to clean them all the same way. And what happens is these tiny fissures are created. And in some cases, we're using surfaces that actually already have microbial reservoirs. Brushed stainless steel is a perfect example of that. If you look at the instruction for use, you will see that they actually state that you must clean in the direction of the texture in order to efficiently clean it. And brushed stainless steel is actually commonly used in the healthcare setting for handrails. They're used in the restrooms, etc. So we're at a disadvantage already because we've designed this area with these types of materials that are difficult to clean. So let's look at a real world setting, okay? When you're selecting surfaces, there are seven aspects that you truly need to look at. We won't go through all of those today, but right now I want to talk about these are real world settings. You need to understand the location. So the photo on the right is actually, we've moved to a universal patient bathroom, which is the photograph on the right. And in this bathroom, we have a toilet. Most people don't think about the fact that when you flush that toilet, it creates a plume that explodes into the air and contaminates the surrounding surfaces. Now, the contents that were put into the toilet is what explodes. So now we know that this is a high contaminated area that needs to be effectively cleaned and disinfected on a daily basis. In this room, the design is not conducive for effective cleaning and disinfection. You have grout, you have ceramic tile, you have brushed stainless steel. And so when an environmental services professional has 10 minutes to actually clean the room on a daily basis, they're already set up for failure in this specific area. You also have a curtain that is a fabric. So a lot of times when a microbe gets on that, it'll actually attach. And then the same is true with the floor. There are solutions to this. You can actually put, for instance, a solid surface material can go from the floor to the ceiling and actually cove into the floor. The material can cove into the floor. So when it's mopped, the floor is actually getting cleaned and there's not a ridge around the edge that needs to be cleaned and is not done so frequently. Another thing to point out in this bathroom is the sink. One of the issues is splash that can come from a sink. So this one, and Sarah, correct me if I'm wrong, this one, there's an advantage to this because there are no counter space next to it where a patient's belongings can be. Do you want to talk about that for a second, Sarah?
Yeah, thank you, Linda. Yeah, so if you think about, especially in a patient's room where there might be a hand washing sink and then a counter that's adjacent to it, and the rooms often have very little counter space or places to put the items that you need to care for that patient. And so we find that those items get placed right next to that sink. And then when the sink's used, any organisms that are either in the sink itself or in the drain of the sink can then splash up onto the countertop or onto the patient care items that are there right next to the sink. We've seen outbreaks in special populations like the NICU related to Pseudomonas, that is a common water bug that can contaminate those products. And then if they're used on that patient, or if it's picked up on the hands of the caregivers that are working in that space, and those hands are not washed appropriately or disinfected before they take care of the patient, or even if they use the item on the patient, then there's a potential for contamination and exposure to that.
And we have one example on our scientific advisory board. Mary Millard is one of our members, and she actually contracted Pseudomonas from an ECMO machine. So the lead wires on the ECMO machine were actually on a counter, and the splash from the sink got on the lead wires of the ECMO machine. And when they inserted that into her leg, she contracted this pathogen. And so it's definitely, there's research that shows that this is happening. And again, if we designed these differently, we could address those issues. The other photo, this was a project that I worked on many years ago. This is actually a sterile processing area. And this is where they clean the instruments that come out of surgery. And originally, this room, the countertop and the sink, so the countertop was a laminate material, and the sinks were not deep enough for the equipment and material. So the first time I walked into this room, there were towels everywhere, and the towels were actually covering delaminated countertops because, of course, this is a very wet area, and they would tap their instruments on the edge of the surface to knock out bone chips and some of those types of things. And the sink, the splash coming out of the sink was a nightmare. So what we did here is, number one, they chose a solid surface material, and you can see the pretty pink band there. What they did is they actually used that to make the sink significantly deeper so that there wasn't the issue of the splash any longer. So again, surfaces that could be used to solve an issue, and wet counters, delaminated counters, etc., can create incredible microbial reservoirs, and pathogens can live and breed in those areas. So these are just a couple of issues that exist. The other thing I just want to say quickly about tile, because that is one of the products, it's inexpensive. It's often selected because it is inexpensive, but grout and the tile itself have to be cleaned different. There are different instructions for cleaning and disinfecting those. And again, if you don't actually clean them the way that they're recommended, the grout will begin to break down. And I have been in destructive investigations where they have actually peeled the tile off of the wall, and it was full of mold as a result of the leaking that took place with the grout as it broke down. So again, design considerations are really critical based on the location and how often these surfaces need to be cleaned and disinfected, and with what. So I'm going to just touch on this. Sarah's going to talk more about instructions for use. Oftentimes, people don't understand that instructions for use in the United States right now, the Joint Commission has now said they are going to enforce instructions for use. That has always been, that's always existed, but they're getting much more firm about that issue. What people don't understand is that manufacturers create instructions for use for every single product that is in the environment, and they are not the same. And so what happens in a situation such as we have photographed here, we have a trauma room, and that trauma room has to be turned over in 20 minutes. There are infection prevention guidelines around the requirement for cleaning this area and disinfecting it, along with all of the instructions for use. And there are over 40 different instructions for use in this one area. And so, unfortunately, whoever is responsible for cleaning this has a huge job, or the regulatory agency could potentially fine them. And when I talk about a fine, one of our advisory board members was fined $10,000 for one infraction in following an IFU. And so it is not a cheap, inexpensive fine. You know, it's not $50 to $75. And Sarah, I know you're going to talk about this in a minute, but she and I had a conversation about what happens if you can't follow the IFU. So Sarah, can you just quickly tell me that story about the IFU and what you have to do if you can't follow it?
Yeah, and I definitely will go into that in more detail, but certainly sometimes when the IFU says what the compatible product is, it's not a product that is suitable for healthcare. So for example, there was a common piece of equipment that's used to cool patients in cardiac surgery. And the product that was recommended to use based on the compatibility was Pine Sol. And if you think about Pine Sol is not something, it's something certainly that we could use in our homes, you know, to clean and disinfect our surfaces. But when you think about healthcare and we have multi-drug resistant organisms and pathogens that are really difficult to get rid of, something like Pine Sol is not going to be effective. So that really puts the healthcare provider facility in a conundrum. And Joint Commission does have kind of a hierarchy of what you need to do if you cannot follow the instructions for use. And so we'll go into that in a little bit more detail in just a moment as well.
Thank you. The other issue here is that you can see from this photograph how far reaching the body fluids are. You can see the blood splattered on not only the medical device that's in the room, but also the walls behind it. And the Accountable Care Act requires this, the hospital will set a amount of time that you can have to work on these rooms. Now, I do know infection preventionists oftentimes will expand that if they don't feel the room is clean, but 20 minutes to turn over a room like this is not sufficient time. So there's many different aspects of a problem that need to be addressed, but I just wanted to point that out for you. So Sarah is going to cover instruction for use requirements, and I am going to just go ahead and turn this over to Sarah.
Thanks, Linda. So as we started to talk to just a moment ago with instructions for use, I wanted to go into a little bit more detail of what's required. So as Linda alluded to, the Food and Drug Administration really requires that any manufacturer of a medical device or an instrument that they provide instructions on how to clean and how to disinfect these items. We know that each item needs to be cleaned and disinfected in a different way based on how the piece of equipment is put together. If there's different types of surfaces, those items might need to be cleaned with a different product. So the IFU needs to tell the user the level and frequency of disinfection. I'll go into this Spalding classification in just a moment, but the level of disinfection might be something like high-level disinfection or sterilization. They also tell us which products are compatible to use on them. So depending on the material that the product was made with might require a specific chemical to disinfect and clean it. So it's very important for the user to understand what those requirements are to ensure that they will not void their warranty and that the product will not degrade faster than what's expected. Additionally, there's some instrumentation that might require a certain number of re-sterilization or re-disinfection processes before the item needs to be thrown away and replaced. So a couple of examples of this that we commonly see in hospitals, in our sleep labs, we have masks that can either be disposable or reusable, but the reusable ones have a minimum or a maximum, excuse me, a time frame of 15 to 20 uses. So that means that the product can be disinfected 15 to 20 times, depending on the specific product that you have, and then it has to be discarded. So when we're thinking about long-term and needing to, purchase new products to replace those, you have to be thinking about that. You also have to be thinking about how are you going to track that? How are you going to keep track of which number of reprocessing you're on for that specific product? Another common instrumentation that has this similar number of times that it can be reprocessed is our robotic surgery instrumentation, and it can only be reprocessed 10 times. So just something to add another layer of complexity. And as Linda already mentioned, we have regulatory agencies that are really keeping an eye on this. And it's because there has been infections that have occurred or outbreaks that have occurred related to products not being cleaned and disinfected appropriately, or that the product could not be cleaned and disinfected appropriately based on how it was built. So a good example of this is our endoscopes. There's a specific endoscope called a duodenoscope. You may have seen that there was outbreaks and continues to be outbreaks related to these scopes. And it's because there's a channel and a little mechanism inside of them that makes it really, really difficult for it to be cleaned effectively. And the biofilm that Linda was talking about just a minute ago, that biofilm forms in that section. And then when the scope is used on the next patient, then if there's an organism that's been hiding out in that biofilm, it can be potentially passed on to the next patient. So there has been multi-drug resistant organism outbreaks related to those scopes. And so the manufacturers have been working really diligently to look for alternative options like a disposable option, or adjusting the way that that mechanism is made to make it easier to be cleaned. So just one example there. And also, as Linda mentioned, every single item has its own IFU, and that can be very overwhelming for our healthcare facilities and our teams that are taking care of these items to be able to just keep track, because each item may have different products that it needs to use on different elements. So it can really be confusing when you're trying to understand how to utilize the IFU. And of course, we know if we fail to follow those, there is an increased risk to the patient. So the next I want to go into, let me go ahead and see if I can switch the slide here. There we go. So the next thing I wanted to chat with you about is something called the Spalding classification. And the Spalding classification was originally developed as part of research in 1939, but didn't go into practice until many years later. What the Spalding classification tells us is really what level of disinfection needs to be used based on the type of, or the use of the specific item. So if you look on the right-hand side, you have the type of item, how it's used. So starting at the top, you have a critical item. This is an item that is used in sterile tissue or the bloodstream. And a common example of this is our surgical instrumentation. So it needs the highest level of disinfection to make sure that it's going to be safe for the next patient. And what's required for a critical item is sterilization. Sterilization kills everything that's on that item and renders it safe for the next patient. Coming down one level, we have semi-critical. These are devices that contact mucous membranes or non-intact skin. So those endoscopes that I was talking about that you would normally have used on you for colonoscopy, for example, those undergo high-level disinfection. But as we have noted with the outbreak that occurred with our duodenoscopes, a very specific type of endoscope, there may be an opportunity for those scopes to undergo sterilization. However, those, as they're currently made, they cannot undergo the heat or the type of sterilization. There are multiple types of sterilization, but oftentimes those cannot undergo safely without destroying the device, that level of sterilization. So as Linda was mentioning, really looking at what the surfaces are that are making those instruments so that they can undergo the highest level of disinfection possible. The next level is non-critical, and these are your more common areas. So this is things like that do not contact non-intact skin, so only intact skin. So these items are common for environmental cleaning. So these are devices that are used on contact intact skin. And there's two levels of disinfection: low level disinfection, which we commonly see in our environment, and intermediate level disinfection. Intermediate level disinfection means that they might have a short period of time that they have contact with non-intact skin. An example of this is those pools, those water pools that are used in physical therapy offices, oftentimes will require intermediate level in disinfection. And the intermediate level disinfection has just a slightly wider range of pathogens that it kills, the specific product kills. So it's just a little bit more, it's one step up from our low level disinfection. Low level disinfection, when we think about it, is primarily things like those pre-saturated wipes that kill most bacteria and viruses that are commonly found in our healthcare organizations. You may also see chemicals that are diluted and then used with a cloth.
And let me just quickly say, Sarah, that there is some controversy. Well, there's some concern that we now know from research that the non-critical items actually do spread pathogens. So when this was done in 1939, Spalding's classification was developed in 1939. This was before we had the research that we have now. And so there's some controversy around whether or not this should be changed and some discussions. So, you know, for an environmental services professional, it's important that you understand the low-level disinfection and the intermediate level disinfection issues. The other thing I want to quickly say is that we did a case study a few years ago where a medical device needed to be cleaned and disinfected, and the IFU specifically required a quat wipe to be used. In this particular hospital, though, there was a policy where you could not use a quat in the patient care area. So it's important to ask some of those questions as well when you're deciding low level and intermediate level. There's a variety of disinfectants that could exist. So you want to look at the hospital policy to understand which ones are used in their facilities. So
great addition. Thank you, Linda. And some of the items that you might come in contact with low level disinfection, if you think back to that trauma room that Linda was showing us, most of the items in there are going to require low level disinfection. It might be our blood pressure cuffs, the high touch surfaces like the bed, the handrails, you know, our computer keyboards, doorknobs, etc. Those types of things generally require low-level disinfection. So of course, that's going to be the most common in our healthcare settings. The items that are not going to be used on those mucous membranes or sterile tissues. All right, so kind of turning the topic a little bit to the reality, and we've alluded to this a little bit already. But the reality of following an IFU, and as we mentioned, it can be very challenging. For one thing, there is not a standard format. So if you think about our safety data sheets, the SDS sheets that we follow for chemicals, there's a very strict format for that. You have images that you know what it means, regardless of which chemical you're looking at. Unfortunately for IFUs, that doesn't exist. There's definitely a growing understanding that that is needed to help reduce some of the confusion. Additionally, a lot of the documents are very lengthy. They can be hundreds of pages long. And so when you're trying to drill down to where's my cleaning and disinfection elements, that can be challenging to find. And when you have such a big document like that, sometimes the team may stop after the cleaning instructions because there's just too many steps that they get confused and don't even realize that they haven't gotten to the disinfection steps. And that's something that's really important when you're thinking about disinfection is the item has to be cleaned. You have to remove that visible soil before you can move to the disinfection step. And so if we do not follow the disinfection step, then we're not rendering that product or a piece of equipment safe for the patient. And then as Linda mentioned earlier, when we have something like the Spalding classification doesn't match the intended use for the IFU. So one example that comes to mind is our instruments that are used on eyes. So a lot of times, like when you're going in and having your eyes checked, a lot of those pieces of equipment, the IFUs tell you disinfectant, but it's a low-level disinfectant. It doesn't meet the high-level disinfection standard that it should. So that puts the healthcare provider and facility in a challenging position. So what happens when you can't meet that IFU? It really takes looking at what other recommendations are out there from our national guidelines or evidence-based practice. If that doesn't exist, then are there white papers or position statements that tell you what you should maybe be doing? And if none of that exists, then it's up to the organization to do a risk assessment and determine, weighing those risks versus benefits, what is going to be the best thing to do, especially when we know that the warranty will likely be voided and that the surface will likely be degraded much faster than if we had just been able to use the product. But as I mentioned earlier with the example from the cardiac cooling machine, when you have a disinfectant that's listed that's not going to render the piece of equipment safe for the next patient and be able to kill the organisms that are on it, then that's a higher risk to not use and not follow the IFU than it would be to use a product that's going to make sure that that item is safe for the next patient. And I kind of already talked about this a little bit, but sometimes the compatible products that are listed are not available. So if the piece of equipment was initially developed in another country and then it's being brought to the US to be used, we will not have access to that specific product regularly. And so that also puts you in a challenge. So oftentimes that requires the healthcare provider to reach out to the manufacturer to see if they have additional information that's not listed in their IFU about compatibility. Or you may have to reach out to the manufacturer of a disinfectant product that you're using to see if they have done testing for the instruments or equipment to see if it's compatible from that end. A lot of times the disinfectant companies have done studies to basically look at the type of material that's used on common products that they would be disinfecting. So then you can take that and say, okay, this piece of equipment was made with this type of plastic. The chemical company says, yes, you can use it on that type of plastic. So therefore, kind of by default, you can consider that that might be used for more safely on that specific product. So if you encounter any of these specific examples that I've talked about, then it's really up to the facility or the healthcare provider to conduct a risk assessment to really look at the risks versus the benefits. So switching topics really quick before we round it back out and I hand it back to Linda. So for those of you who have not worked with infection prevention before, we wanted to give you just a little bit of background on who infection preventionists are. And generally speaking, infection preventionists come from clinical background like nursing. We do have a lot of professionals that have been medical providers in other countries that have come and started working in infection prevention. We'll have people with a public health background a lot of times will come into infection prevention. And you may see infection preventionists most commonly in hospitals as it's required for there to be infection preventionists. Additionally, in our skilled nursing facilities, especially after the pandemic, it was very evident that we needed additional support with infection prevention in those long-term type care facilities. So you're starting to see more of a requirement there. However, it's not the same depending on what state you're in. So for example, California requires a full FTE to be dedicated to a skilled nursing facility. But in Washington state where I am, you just have to have an infection preventionist, but it doesn't tell you how many hours they're required to do that role. So there is some inequities in how infection prevention is staffed in those areas. We're additionally starting to see infection preventionists more involved in clinics and dialysis, especially as more things move out of the hospital setting and into the ambulatory setting. And then, of course, we have those public health professionals that work in our government agencies like CDC or our local public health jurisdictions. Our non-healthcare settings where you might see an infection preventionist provide consultation would be schools or prisons, especially when there's an outbreak going on. And early during the pandemic, that was definitely a big push to understand how to get people back safely to school. And then in a little bit of a newer area where infection prevention is starting to get involved is our industry setting. So all of those challenges that we talked about with the research and development of instrumentation and devices, having infection prevention involved with the development of those can really help to ensure that they can be cleaned and disinfected appropriately. So basically lots of different avenues that infection preventionists might be involved. So then if you think about where the infection preventionist might be doing in their role, so starting on the left-hand side, the area where you might see or might expect an infection preventionist to work is really looking at healthcare associated infections and things like hand hygiene and making sure patients are in the appropriate isolation precautions, or things like ensuring that we're utilizing our testing and diagnostic stewardship and working with antimicrobial stewardship. We also spend a lot of time working on process improvement and trying to incorporate evidence-based research into practice. And this might be a really big space where infection prevention partners with our housekeeping teams, especially if we're thinking about that room that had the 20-minute turnover as the expectation. So we might look and partner with teams that are required to do that room cleaning to see what types of things could we consider to cut that time down? Could we move to disposable items that could be discarded at the end of the case instead of having to be reprocessed? Are there things that we could take out of that room ahead of time so they don't have to be cleaned if they're not used? Just ways that we can work more efficiently and more effectively. So certainly seeing that partnership. Additionally, looking at the types of products that we're using and the contact time, for example, that is required for that specific chemical to be used. If you can move from a product that requires a 10-minute contact time, so that means that the surface has to remain wet for 10 minutes before it's all of the microorganisms are killed and safe to be used, versus a product that maybe has a 1-minute contact time, that's going to save significantly for the end user who's having to do that process. So definitely a big opportunity here to partner between teams. Epidemiology is looking at our surveillance and reporting that's required, especially by like CDC requires certain surveillance and reporting. We have a lot of interaction with leadership and key stakeholders throughout the organization. I like to say that anything that is within or surrounding the healthcare facility is really under the purview of the infection preventionist, because we know that there's so many different ways that things can come into the facility and then affect both our patients and our team. So we're spending a lot of time keeping our leadership up to date with how we're doing, especially when we're looking at our healthcare associated infection rates. Emergency management and an environment of care is kind of an exciting area that I would say probably most people don't think about, or I should say maybe before the pandemic didn't think about infection preventionists in emergency management. But certainly that came to light at the beginning of the pandemic as we had a new pathogen that we didn't really know a lot about. And we had to make a lot of decisions in the moment based on what we knew from other pathogens. And then we continue to try to be prepared for the new things that are coming. So for example, the changes to the mpox that was just released this week with the World Health Organization and concerns about that. So we're always looking at what's coming and how do we prepare for that. And then the environment of care is another area where we can really partner with our engineering and facilities teams. Anything that from the ceiling to the walls, to the floor, to the air and water, there are so many opportunities for things to go wrong in that space. Going back to the biofilm that Linda talked about earlier, especially in the pipes of our buildings, especially if they're older buildings, there's a lot of biofilm that can build up in those. And then that makes for a very concerning potential risk to our patients if we do not have mitigation strategies in place to decrease the organisms in there. Additionally, with construction safety, and this is an area where there's been a lot of work with infection prevention, is ensuring that we are separating spaces from patient care areas and our construction work, as we know that different molds and different bacteria can be released when we're taking down old types of buildings or above the ceiling spaces. So we want to make sure that the air is protected from the patient care area where we're working. We talked a lot about cleaning and disinfection and then a little bit about product evaluation, but you can see that infection prevention is involved in a lot of different ways, and we want to partner with our key stakeholders to really understand, you as the expert in your field, how we can help to keep our patients safe. And I think with that, I hand it back to you, Linda.
Thanks so much, Sarah. It is such a pleasure to work with our infection prevention team and our experts on our advisory board, because it's such a great collaboration of things. We had an advisory board meeting and we lost, 3 of you due to emergencies within the hospital in that 1 hour of meeting. So they play a very key role. And one of the things that we want to start adding to our training with HSI is to be able to incorporate the infection prevention in with the environmental services professional, because they are a key stakeholder and the alliance is so critical to make sure that our patients are safe. So as we come to the end of this presentation, I want to tell you a little bit about how you can actually get involved with the Healthcare Services Institute. So we talked about our 15 professional advisors that exist. You can see all of them on the HSI website. We also have some of them that are available for consulting. And so we have a couple of consulting opportunities with the Institute, one around IFUs and doing research, and then the other one around just consulting on, a variety of different topics, in particular, the selection of surfaces. We also have our task force. So the way that the Institute actually does our work is on task forces. We do have an IFU task force. It was formed. We are aligning with APEC. APEC is working more on the government side of the IFU issue. HSI is working on creating a standard template and way for writing IFUs, so they're similar to the ASDS. And at our summit that's coming up in November, we will be also creating additional task forces. And so we hope that you'll join us. We also have a variety of different webinars, some of which are online through the HSI website. And we will be launching in November at the summit our Surfaces and Products Selection Micro Certification Program. And that is actually a series of 6 classes that you would take, and you would receive a certification at the end. It is training for how do we select materials and products for a healthcare setting. We also have a variety of town halls. Our last one was Beyond Disinfection, where we talked about the root causes for the challenges that we're faced with in our healthcare settings. And then finally, we are so excited. Every year prior to COVID, we had a Healthcare Surfaces Summit. The summit is not like any other conference that you go to where you sit in a training session and then hear the latest research, etc. We do a training session, but at the end of those sessions, we have an interactive discussion with the audience. The goal is to begin collaborative efforts in creating solutions to those issues. And so at the end of our summit, we typically have several task forces that have been formed, and they have a scope of work for the year. So we've had research projects come out of that. We had a case study that ended up coming out of that. We did a literature review. So every year we have bodies of work. So we're not just talking about a problem, we're coming up with a solution. And so we would love to have you get involved and advocate and support for the changes that we need. Surfaces is an overlooked issue, and that is one of the root causes for the problems we're faced with. Infection rates aren't going down. We need to start at design and look at how we can support our environmental services and infection prevention professionals by creating products that can easily be cleaned and disinfected. And with the support of HSI, we hope we're headed in the right direction. And let's see. Sarah, it looks like you answered quite a few questions. Please put any questions you may have in the chat box and in the Q&A, and we will ask them and answer them. And otherwise, I would like to thank everyone for joining us. This was recorded. My understanding is it will be on the ISSA YouTube channel. We will also put it on our HSI website. And we invite all of you to join the Institute and get involved. We're looking for solutions, and we want to make changes in the healthcare setting that support the reduction of infection prevention. Anybody have any questions that we can
Not
answer?
seeing any more in the chat or in the Q&A.
Okay. Did we scare anyone? I always think we should have a warning that comes up first. You may not ever want to go into a healthcare setting again. It's not that bad. It isn't, but some of this information can be pretty telling. All right. Well, Sarah, it has been a pleasure to do this with you. Sarah will be at the summit along with the rest of our advisory board. We invite all of you to join us. And with that, I think we can end the webinar.
All right. Well, thank you, Linda. It was a joy doing this presentation with you all as well. And sorry about the little bit of a tickle in my throat. Appreciate the time today. Hope you learned something new that you might not have learned before, and hope to see all of you at the summit.
All right. Thanks, everybody.